our topic is on SIDH, and I'm going to talk on the topic.
Can you talk a little louder because I can't hear you?
Okay, in SIDH, what happens is the feedback mechanism that controls the ADH release is messed up, really. And malfunctions. So what happens is that the normal thing is when the plasma osmolarity is reduced, the ADH is supposed to be inhibited. But with SIADH, that doesn't happen. So what happens is the ADH is continuously released even when the plasma osmolarity is low. And then because of that, you have water retention and dilutional hyponatremia. And with increased plasma volume, leads to increased PFR, that's glomerular filtration rate, and that causes an inhibition of aldosterone and renin release. And when that happens, more sodium is lost from the urine, and that increases the hyponatremia.
Okay, some causes of malignancies like the small cell carcinoma of the lung and Hodgkin's lymphoma and non-Hodgkin's lymphoma. Pulmonary diseases such as viral or bacterial pneumonia, pneumothorax.
Say that again, please.
Viral and bacterial pneumonia.
Before that.
Oh, pulmonary disorders.
Say that again, please.
Pulmonary disorders.
That's one of the most common reasons, either head injuries or lung CA or COPD, those are the most common reasons.
Yeah, it had quite a few pulmonary disorders, even like positive
You don't have to
pressure,
name them all.
ventilation. You don't have to know them all.
Well, just no pulmonary
disorders.
and brain injuries.
Yeah, then some others were the central nervous system disorders like trauma, infection, tumors, strokes. So I guess trauma was one you mentioned. And then some drugs like exogenous, ADH, opioids, tricylitic antidepressants, and general anesthesia. Just some. There's a lot of causes. But
Okay, so if we use Davinase and lithium to treat diabetes insipidus, what can those cause?
Oh, but they said it caused it, didn't they? Or am I deaf?
No, that's what the book says. It says it costs.
It causes it, right?
Diabetes insipidus?
Yeah.
That's what she was saying.
Sorry, I'm confused.
Okay, but they use it as a treatment, right? Okay.
Okay, manifestations. Early,
I'm not gonna ask on the test, but I need to clarify that for you.
Okay, thank you.
Okay.
related to water retention, GI disturbances, and loss of appetite, nausea, vomiting. A lot of it is either from a lot of the manifestations are from low sodium or high fluid retention. On the central nervous system, you can have lethargy, headache, hostility, disorientation, change in altered level of consciousness. And it can progress to seizures and coma.
What's all that describing? What does that say?
Hyponatremia.
Huh?
Hyponatremia.
Where's the fluid going?
Oh,
Increase intracranial pressure. Well, a lot of that is, that's severe, but.
and then just monitor for indicators of fluid overload, the bounding pulse, JVD, crackles in the lung, peripheral edema, and reduced urine output.
Okay, so looking up there, what do you think the urine alcohol up here is going to look like?
It's gonna be high.
High, okay. Okay, let's see what else.
Can you just hold up?
Thanks, sorry, Alex. So for interventions and evaluations, of course, because of the decreased urine output, you
to help with the fluid volume overload. And it can be as low as 500 to 600 milliliters in 24 hours, but whenever I researched it, it said usual is about 8 to 100 milliliters per day, and that includes what you give them with their medications. Of course, ice chips you want to provide because they're going to have some discomfort and be thirsty. I think we've all had patients that are like, I'm thirsty. Well, you're NPO, so you can't have anything. These patients aren't necessarily NPO, so you can give them ice chips or some sugarless gum to help with their discomfort from thirst. And you want to provide frequent oral care, and that also goes along with some medications that you'll administer, which we'll talk about. And because of their altered level of consciousness, you want to make sure that you have a bed alarm on and that you assist your patients with ambulation, just to make sure that they don't fall. And then you also want to check, do neuro checks, and make sure they're oriented ×3 every 2 hours to make sure that there's not a change that you didn't realize. And some medications that you may administer. You may administer diuretics, but of course with that you've got to watch your sodium loss, because that would further your hypernatremic state, so would just exacerbate these symptoms. And then if you have a really, really, really low sodium level, they may administer and prescribe hypertonic saline, which would be the 3% sodium chloride, to help with that, which you want to give cautiously and slowly because you're giving a fluid and they're retaining the fluid, so you could exacerbate the fluid overload. And then declamycin, it's a type of antibiotic, and if you give that, you want to make sure that you check the mouth daily for yeast, maybe even have them eat some yogurt, because they're killing all of their good bacteria, so that's just reinforcing that. And of course you want to monitor, like she said, for signs and symptoms of fluid volume excess, for jugular vein distension, bounding pulses, crackles, edema, and you want to make sure to watch for a sudden weight gain that isn't manifested by edema, because it could be internal, increased cranial pressure, like you said, or pulmonary edema, where you can't see it necessarily, but it's there. And
Did your book mention the renal escape mechanism? Okay. That's a protection of the kidney, and that's one reason why you don't have the peripheral edema. But I just wondered if it was 80 or 10 don't worry about it. Go ahead.
That is, I think I've got all of these that I listed. Questions?